Chapter 27. Anxiety. As of now, you understand that anxiety should not be avoided. Anxiety is simply an emotional response to dangers, a job, a new assignment, an exam, etc. It is a feeling of discomfort, apprehension, or dread related to anticipation of danger, the source of which is often nonspecific or unknown. Anxiety is considered a disorder, or pathological, when fears and anxieties are excessive, in a cultural context, and there are associated behavioral disturbances such as interference with social and occupational functioning. Anxiety disorders are the most common of all psychiatric illnesses and result in considerable functional impairment and distress. Statistically speaking, anxiety is the most common of all mental health conditions, followed by depression. Anxiety disorders commonly occur in women, sometimes due to hormonal fluctuations. Clients diagnosed with anxiety usually have a history of trauma during childhood or were abused as children. It is very important to understand the difference between anxiety and fear. Fear is a cognitive response to threats. Fear requires a thought process. On the other hand, anxiety is just an emotional response, a vague feeling to a situation. Let's talk about some types of anxiety. Generalized anxiety disorder, GAD. It is a chronic excessive anxiety/worry lasting 6 months or longer. This is a key information to remember. GAD is usually not due to caffeine consumption or thyroid disease. Some symptoms of GAD include restlessness, appetite changes, muscle tension, and procrastination. Remember we mentioned that anxiety should not be avoided? In the same perspective, it should be maintained to the lowest level possible. If a client allows it to interfere with their daily life, in that case, it is abnormal or pathological. Once anxiety becomes excessive and persistent, the root causes of anxiety should be addressed as soon as possible. Otherwise, it may lead to a panic attack or crisis. Panic attack or crisis are the two most important concepts to remember. Panic-level anxiety is characterized by a sudden, overwhelming feeling of terror or impending doom. Intense and frightening symptoms. Panic attack usually lasts from a few minutes to 30 minutes. Clients with panic-level anxiety have an emotional feeling of impending doom. They are shaking, complain of chest palpitations or chest pain, sweating, and abdominal distress. Below are some fundamental questions to ask yourself. What are some symptoms of uncontrolled anxiety/crisis? Escalating anxiety from a threat activates increased defense responses. Anxiety continues escalating as defense responses fail, functioning becomes disorganized, and the client resorts to trial and error attempts to resolve anxiety. How does panic anxiety differ from crisis? Usually lasts a few minutes, while a crisis lasts months. A crisis is an acute, time-limited, usually lasting 4 to 6 weeks, event during which a client experiences an emotional response that cannot be managed with the client's normal coping mechanisms. Panic disorder simply entails recurrent panic attacks with intense physical discomfort. Some individuals may have attacks of moderate severity weekly, others may have less severe or limited symptom attacks several times a week. What would be your nursing intervention for a patient with a panic attack? Stay with the patient during a panic anxiety attack. Patient may have a fear of dying. Maintain a calm therapeutic approach. Use simple words and sentences in a clear and calm manner. Keep a low stimulus environment. Encourage relaxation techniques. This is usually done once clients calm down. Use anti-anxiety medication. Once calm, help the patient identify causative factors for anxiety. Discuss other coping mechanisms with the presence of escalating anxiety, exercise, meditation, yoga, deep breathing, also when they are calm. Let's talk about phobias. Phobias are persistent and irrational fears. They consist of intense anxiety and panic attacks when exposed to the feared object or situation. Some of examples of phobias include agoraphobia, which is the fear of being in open spaces. Clients are preoccupied with how they may escape. Examples include public buses, cinemas, theaters, concerts, etc. Another type of phobia is separation anxiety disorder. Even the idea of separating from their loved ones makes a person develop excessive fear. It is usually normal among 18-month to 3-year-old children. However, after that period, it interferes with age-appropriate behavior. Social anxiety disorder, also known as social phobias. Clients with social anxiety disorder are afraid of social performance, social situations, because they may be exposed to scrutiny by other people. Such people may fear speaking or eating in public places. They fear how others judge or perceive them. Anxiety disorders due to medical conditions. As the name implies, these disorders are usually due to chronic disorders, such as COPD, CHF, and seizures. They can also be caused by substance abuse, including medications. Some acute conditions, such as myocardial infarction, may also provoke them. Substance-induced anxiety. This disorder may be caused by substance abuse. Substance-induced anxiety disorder is only diagnosed if the anxiety symptoms are in excess of those usually associated with the intoxication or withdrawal syndrome. It may be due to alcohol, amphetamines, cocaine, hallucinogens, sedatives, hypnotics, anxiolytics, caffeine, cannabis, or other substances. Obsessive-compulsive disorder. This is also known as OCD. It is divided into two components. The first component of OCD consists of obsessions. Repeated and unwanted thoughts leading to anxiety. The second component of OCD consists of compulsions. Repetitive behaviors are used by clients to reduce or relieve anxiety or distress caused by obsessions. How do clients with OCD present? They can either have obsessions or compulsions, which leads to social or occupational impairment. The individual recognizes that the behavior is excessive or unreasonable, but is compelled to continue the act. Common compulsions include hand-washing, ordering, checking, praying, counting, and repeating words silently. What medications can clients with OCD get? SSRIs. However, OCD patients usually receive a higher dose, for example, a double dose, than clients with depression. Body dysmorphic disorder. As you see in the picture, body dysmorphic disorder is anxiety due to perceived body deformation or defects. The most common complaints involve perceived defects in skin, such as wrinkles or scars, the shape or size of the nose, or hair. Though not real, for others, such anxiety may lead to depression and OCD. It is often exaggerated. Trichotillomania, also known as hair pulling disorder. Clients with this disorder engage in routines of pulling their hair, most commonly women, due to tension or anxiety. They have a feeling of gratification once they pull it. The disorder starts in adolescence and continues during adulthood. Due to its effect on reducing anxiety, it is sometimes considered within the OCD spectrum. Hoarding disorder. This is simply the inability to let go of possessions you no longer need, quite often of no value. Also, acquiring more items continuously that you don't necessarily need may be considered hoarding. This is more common in men. As these people grow older, the disorder gets more severe. Hoarding disorder is associated with high comorbidity for dependent, avoidant, schizotypal, and paranoid personality disorders. Some of the treatment modalities and therapies include psychotherapy, preferably individualized, and later can be group therapy. Cognitive behavior therapy, also known as CBT, helps to reduce anxiety responses by altering cognitive distortions. Other treatments include meditation, imagery, and muscle relaxation. Behavioral therapies, such as relaxation treatment, modeling, systematic desensitization, and flooding, help many clients with anxiety disorders. Thought stopping involves telling the thoughts or compulsions to stop and may help with OCD. Anxiolytics or anti-anxiety medications are used in the treatment of anxiety disorders and symptoms. They include, for example, lorazepam or Ativan, alprazolam or Xanax, clonazepam or Klonopin. Outcomes for anxiety disorders and phobias. The most important outcome we want to achieve is for the client to be able to reduce and manage their anxiety. For example, how can you intervene if the clients are experiencing obsessions/compulsions? Understand that patients engage in OCDs to cope with anxiety. Maintain anxiety without resorting to OCD behaviors. Demonstrates adaptive coping mechanisms for dealing with anxiety instead of OCD behaviors. How can you help patients cope with phobias? Maintain a calm therapeutic approach. Discuss other coping mechanisms. Let's talk about the difference between acute and post-traumatic stress disorder. Stress-related disorders are often experienced by veterans and patients who witnessed or experienced violence. ASD and PTSD patients were both exposed to traumatic events. However, acute traumatic disorder, ASD, lasts for at least 3 days and less than 1 month. On the other hand, post-traumatic stress disorder, or PTSD, lasts longer than 1 month and can last for several years. Some clinical manifestations for ASD and PTSD include the following. Both clients can have flashbacks, nightmares, anger or irritability, guilt feeling, insomnia, isolation, and/or dissociation. Both clients can experience inability to focus, which is of course temporary for ASD and long-term for PTSD. Insomnia, sleep disturbances, and depressive symptoms are common. Suicidal ideation or homicidal thoughts, especially in PTSD patients. Hypervigilance is usually noted in clients with PTSD. So is anhedonia, which is the inability to experience pleasure. Therapies include CBT, psychotherapy, and/or prolonged exposure therapy, which involves relaxation techniques while simulating or actually exposing the client to a traumatic situation. Eye desensitization therapy also helps reprocess their memories of trauma, with their eyes distracted by moving lights or waving a pencil in front of them. It is beneficial, especially for PTSD. Some of the nursing interventions for clients who experience trauma consist of validating their feelings, staying with them in case of flashbacks, only discussing past traumas if clients allow it, avoiding changing staff, and maintaining a calm approach. Let's review the interventions for clients with traumatic disorders. What are some of the risk factors for PTSD? Exposure to traumatic events causes anxiety, detachment, and other manifestations for longer than 1 month and can last for years. How can you help the client cope with PTSD? Validate the patient's feelings. Stay with the patient during periods of flashbacks, nightmares. Encourage the patient to discuss their trauma at their own pace. Discuss various coping strategies, maladaptive versus adaptive. What could be an example of maladaptive coping strategies? Alcohol or smoking hashish.